training and technical assistance to, we currently have 13 local affiliates. They're local and regional. And we have some building affiliates that are kind of under our umbrella right now that are starting to run NAMI programs. I will cover a little bit more about NAMI programs and services later, but what I've been doing over the past couple of years that I've been with NAMI is I've been the program manager, but when we received a disabilities grant with IowaCASA, I transitioned over to grants administration and have been working primarily on the SAMI project with Nadia and IowaCASA. So I also at NAMI, I do a lot of legislative advocacy for criminal justice reform. I liaise with rural providers, especially giving technical assistance on peer and family-led programming and peer support, as well as mental health services that are available across the state. I do provide technical assistance through our helpline, and through anybody that happens to call and need some assistance finding mental health resources, services, some level of co-advocacy with some of the resources in their area, and that's for statewide. And I am also a certified NAMI provider teacher. So I am able to, with a team, go into medical schools and to service agencies, clinics, and provide training on NAMI's collaborative model of care for people with mental illness. I am also a certified recovery specialist, and previous to NAMI, I spent about 4.5 years in the field serving in an integrated health home. I provided a lot of care coordination, as well as it's kind of a bridge to therapy. We work on coping skills. We can help back up what they're learning in therapy and provide some practical solutions and practice for that. You'll hear more about that as well as recovery specialist or peer support specialist. And that is someone who is certified by the state. We take a certain amount of training, and we have to pass testing and recertification and continuing education. The unique part of that is that I get to identify to the folks that I serve that I live with a mental illness myself. I can also identify that I am a survivor, and we're trained to use recovery stories to help our clients through whatever they may be going through and create those connections that can help them get into higher level services, or just help them empower them to live as independently as possible, and to live in what their definition of recovery is. So my specialty has been working with survivors, especially of trauma, who live with mental illness. And in the program that I work with, the mental illness predates the survivorship of the trauma in many cases. So we're talking about anywhere from anxiety and depression to personality disorders on up to what are often called serious mental illness, including psychotic disorders and major mood disorders like major depression and bipolar disorder. I also did a lot of Medicaid access work. I did a lot of crisis work, and specialized in working with clients with personality disorders. So that's kind of where I go with this today, because it's a big overlap with survivors of trauma. And then I also specialized in working with returning citizens. Currently, I'm also a student in psychology and neuroscience at Drake, and I am also doing some work on international relations and human rights. So I want to preface everything that I say today in that I'm not licensed to make diagnoses. I don't make diagnoses. We'll talk about some symptoms or some scenarios or behaviors that you might notice in people with certain diagnoses or mental illness, or that might be an indication of that, that in no way means that we can make a diagnosis and say that that person has that, that condition. So I want to make that clear. You know, a lot of what I did do was work with therapists and providers with the permission of my clients to kind of help flesh out what the particular diagnosis would be so that they could get proper treatment. So just want to put that caveat out there. We're not diagnosing anybody today. If you have a scenario that you want some help with, you know, certainly I can give you some ideas based on what some of the behaviors might be, but there will be no, like, this person has this diagnosis. So I will, that's in a nutshell who I am and what I do and what you get if you need to call me for assistance. So
Thank you. You just do a little things here and there.
yeah, a little bit of everything.
All right. So let's talk about mental health considerations for survivors during a world pandemic. So today we are going to identify shifts in mental health during a pandemic. We're also going to identify new barriers to access, unique. We are going to discuss complex trauma, identify accessible solutions, and discuss how advocates can keep themselves safe. So to start off, I want to set the tone for how we're thinking about survivors who are living with mental illness. Typically in this work, when we talk about mental illness, we tend to just focus on anxiety and depression, and those are the most visible in regards to mental illness, but there are a variety of other illnesses and conditions that we tend to forget about. So we have personality disorders, that includes borderline personality disorder, dependent, dissociative identity disorder, or DID, eating disorders, so anorexia, bulimia, binge eating disorder, pica and purging disorder, mood disorders, which is where we tend to focus, depression and bipolar disorder. And then we have anxiety and panic disorders, so obsessive compulsive disorder, or OCD, post-traumatic stress disorder, or PTSD, and then psychotic disorders, or what is considered serious mental illnesses, so schizophrenia, schizoaffective disorder. I do, with the check-in on how we're talking about mental illness, I also want to address that typically in our work, when we talk about survivors who are living with mental illness tends to be spoken about as a symptom of their victimization. So when we talk about depression or anxiety or PTSD, it's due to their victimization. But today we really want to focus on folks who were already living with mental illness, who are now at greater risk of victimization, and how they're dealing with things now. Also, pointing out that women are more likely to be diagnosed with borderline personality disorder, borderline personality disorders, and men are more likely to be diagnosed with narcissistic personality disorder. And I know Heather will speak more on that, on the gendered diagnoses. Again, to remind you guys, if you guys have any questions, feel free to raise your hand or send something in the Q&A box or chat box. So complex trauma, as we know, we all know about complex trauma. It is the result of multiple experiences in a person's life that each individually create a traumatic reaction. In this work, we talk a lot about complex trauma, but we're very good about discussing it with each other, talking about it in trainings or presentations or community education sessions, or even assisting some of our clients with better understanding some of the barriers that they're facing or struggles that they're dealing with. But oftentimes when we're faced with complex trauma, or our client that we're actively working with is presenting a lot of, not them presenting barriers, but they are facing a lot of barriers, we tend to forget about complex trauma. We're really good about talking about the intricacies of it and how it can play into survivor responses. But then when we're in front of it and it's happening, we don't have that consideration anymore. And we need to do better about that. And so keep that in mind as we talk. Also, when we talk about complex trauma, it's usually past tense. We usually identify these past experiences that have now created complex trauma, but keep in mind that complex trauma is developing now with this world pandemic, and we need to keep that in mind because complex trauma is not just physical violence. It can be socioeconomical violence. There's other forms of trauma that tie into complex trauma. So racism, xenophobia, world pandemic, genocide, things like that. So biology of trauma. Experiencing trauma can lead to biological changes, that are highly associated with PTSD, other mental illnesses, and substance dependency. These include changes in the limbic system functioning. Our limbic system focuses on is in control of our emotions and memory. Our hypothalamic pituitary adrenal axis, or HPA axis, I'm going to refer to it moving forward as HPA axis. So the HPA axis activity changes with variable cortisol levels. This HPA axis plays key roles in the body's response to stress. The major pathway of the axis results in the production and secretion of cortisol. This activates the flight, fight, or freeze stress and response by causing adrenals to produce adrenaline and cortisol. So think of cortisol as nature's built-in alarm system. It's your body's main stress hormone. It works with certain parts of your brain to control your mood, motivation, and fear. Another change that we see is neurotransmitter-related dysregulation of arousal and and I always mess up this word. Help me out, Heather. Endogenous.
Endogenous. Sorry, I was looking ahead at my notes. I apologize. Yes, endogenous.
Words. Arousal endogenous opioid systems. So when we think of arousal, we see this change or dysregulation. That usually the symptom of that, or what that turns into, is hypervigilance. And then for the opioid system, that's our innate pain relieving systems. Heather, I'll let you go.
Okay. So this can all create different ways that survivors will present, and what Nadia just talked about actually leads into especially when it happens when we're young and as children, leads into the development of the personality, because all of these systems are also, part of how we learn. Every learning system, goes through these chemical pathways, and in some cases, especially, considering like the cortisol response and those endogenous opioids, those feel-good chemicals, the brain learns early on to depend on those. And when they're not present, sometimes that can lead into seeking out some of those situations that will create those same chemicals. And sometimes those situations are risky. Sometimes they lead to behaviors of self-harm, or just putting oneself at risk, or maybe it's creating drama because that, when I have drama, it releases some endorphins, and then I feel better. So that's some of the stuff that can kind of actually meld into the creation of the personality. And this is some of where my scholarship is going. But there's all kinds of theories about how this happens, but there's more and more going into the neurology of how that happens. And when we talk about especially like implicit bias goes along with this, because that's how our brain learns. We make associations and we make shortcuts. And so in folks who have experienced trauma, their brain has also created a shortcut to, how do I feel good? How do I associate this with learning about life and who I am? And so I think a lot of what mental health providers in particular struggle with, as well as advocates see a lot of, are some of these we call them cluster B personality disorders. And keep in mind, I'm not a clinician. This is all coming from my work in the field with clinicians, and also with directly with clients who have personality disorders. So when we talk about cluster B personality disorders, those tend to be some of the more common, especially among trauma survivors. And they include various diagnoses, such as you'll hear borderline personality disorder a lot. That tends to be the most common. But going along with that are dependent personality disorder. And I apologize in advance, I did not name this one, histrionic personality disorder. I tend not to like to use that, and I think it's falling out of favor. Just because, as Nadia mentioned before, a lot of these personality disorders and a lot of what we consider symptoms of mental illness are based on very gendered ideas. So with people with personality disorders and some other cluster B disorders, they'll kind of shift in between. They may already experience feelings of emptiness, fear of abandonment. A lot of it is trouble regulating emotions. And there may be normalization of crisis that, considering the limbic system and the HPA axis and all the chemicals that their brain has learned to depend on. Those come up in crises, and can, in order for the brain to deal with it, can set off some of those pleasure centers in the brain. So, and then for borderline personality disorder, and I would include narcissistic personality disorder in this as well. Splitting is something that a lot of service providers tend to notice, that in talking with survivors or in talking with someone with a personality disorder, they'll talk about someone in a way that they're either all good and kind of putting them up on a pedestal, or they're all bad. They're just like an evil human being. And that's kind of exaggerating a little bit, but it's a lot of black and white thinking. And so service providers and advocates might experience the receiving end of that as well. So I wanted to talk about that a little bit, especially. Really quickly on the gendered ideals. We see a lot of difference in the rates of diagnosis of borderline personality disorder among women, and then higher rates of narcissistic personality disorder among men. And it may be in in some cases that they are the same disorder. And it's just depends on how those how those behaviors come out. Especially when we talk about victims of trauma as well as people who do harm. We see people who do harm often as we stereotype that as a male thing, and then we often tend to say that they're narcissistic, as opposed to maybe that person has also been traumatized in their life, and this may be they may act narcissistic and all about me because of a fear of abandonment or feelings of emptiness, and they may take risky behaviors, and they may harm others because they're trying to feel something. So some of what you might run across in a pandemic, especially, this goes for a lot of people. This is not just related to personality disorders. There's a lot of increase of depression and anxiety among everybody right now. But definitely for folks with personality disorders, increased reliance on others, especially service providers, so especially you guys. Increased use of, I have ED up there, that stands for emergency department, and other healthcare services. It is kind of tough right now because everybody's being told, don't go to the ER, don't go to the doctor. So they may need help figuring out what providers can they utilize and when it's appropriate to do that. They may shun help altogether. There may be some feelings of worthlessness and that emptiness, and why do this? There may be increased risk of harm, or they might appear to thrive on the crisis scenario and engage in riskier behavior. They might appear to be like, oh, I'm going to be fine, and they continue to go out and do whatever they want to do, even with potentially putting themselves at risk for the virus, or just other risky behaviors, hypersexualization, or unhealthy relationships and things like that. During this, that might be how they have a crash later on once the crisis is over. And we can go to the next one. So things that you might notice that survivors might say, and again, this is not limited to people with personality disorders. Some things that I have noticed, though, is that especially in times of crisis, and especially when everybody is isolated, people will say things like, my friends have abandoned me, I can't count on anyone, so why bother? You might hear these things, my advocate hates me, or my advocate is worthless, or my doctor or counselor. You never help me, what good are you? There's no use in trying, they're just going to tell me no. So you might see people just, everybody needs everything right now, I'm just going to hear no, why am I going to bother doing what you say I should do to get help? And then going on to actually some more of what we often call serious mental illness. There are varying ways to categorize these. A lot of times when we talk about serious mental illness in mental health providers and insurance companies and things like that, we tend to use the acronym SMI. And that usually includes things like schizophrenia, schizoaffective disorder, delusional disorder. It may also include bipolar disorder, which is actually a mood disorder. But then also in the mood disorder spectrum, you might hear in disorders, major depressive disorder with psychosis and delusional disorder. There are many, many different mental illnesses and triggers for psychotic behavior. So I don't want you to think that if you encounter someone who is under an extreme stressor, and they might be hearing things, or they might have a delusion. They might, they might, think that they are being watched by the government. I don't want you to think that they automatically have schizophrenia or delusional disorder. Those diagnoses. All of these take much longer to make. And then, you also have to consider that people may be self-medicating more with substances at this time too. So the things that they could be experiencing at this time, especially due to isolation, and especially if they don't have as much access to their providers, and sometimes in-home services, they might be more susceptible to their delusions or hallucinations. Their voices might, come on more often. There might be more, there might be new ones. They might be louder, and they don't have access to distractions or people to help with coping skills because of the isolation. Thinking can become more disordered due to stress. And I want to put out there, I actually spoke with a provider yesterday as part of a project that we're doing at NAMI. And what I've been hearing most from a lot of all kinds of different healthcare providers was, of course, that people are presenting with more anxiety and depression. But what this provider told me, she's at a rural healthcare clinic and she does a lot of intakes, is that for the first few weeks of the pandemic and isolation measures, she actually had like a 700% increase in calls about delusions and paranoia, people thinking the government was out to get them, or was watching them, or that this was a conspiracy theory to get to them, or a bioweapon, as well as, even very interestingly, somebody seriously thinking that they are the coronavirus. So, those are things that kind of sound very wild to us, but when somebody already is susceptible to this type of mental illness, these are the things that can come out when you don't have access to providers. And the avenues that we do have access now, like telephone, internet, like the telehealth services, can actually bring on some more of these symptoms. So we're not going to show this video, but it's included in the slides, and we'll send out the link afterwards with the materials that Kelsey sends out. But there is an empathy exercise that we do as part of our provider program that you can take part in by watching this video. It is, if you've ever heard of the Hearing Voices program, it's similar. Usually what we do is we have a set of complete a couple tasks, and you have to draw something a certain way while listening to what's on this video. I encourage you to do this if you can pick a quiet place, and but just have somebody that you can reach out to immediately, because the audio can be distressing for some folks. Some folks handle it just fine. But it gives you an idea of what it's like when you're hearing voices and trying to follow directions from someone, particularly, how we might get frustrated sometimes because we have to repeat directions over and over, or we feel like someone doesn't listen to us about something that they need to do to get a resource, or to get better, or in order to attend their court date and things like that. So I encourage you to do that if you feel like you can. If it's too distressing for you, don't. There's nothing wrong with that. it is for many folks, but it is a safe way to kind of experience just a little bit of what that feels like. And the reason that we go through all of this information with you, that I just want to point out that especially for people with serious mental illness, 25 to 30 years is how much on average is shaved off the lifespan of someone who lives with a mental illness as opposed to someone who doesn't. That is, when I started doing this work in 2014, that was the number that was the reason for the creation of my program. And that is staggering to me. And including for myself, you know, I live with depression and anxiety and PTSD. For me, as also as a cancer survivor and someone who lives with other chronic illnesses, that's a staggering thing for me to think about myself. I always bring that up just because we want to make sure that folks are still also getting their medical services, and why it's so important to co-advocate with their mental health providers where possible, because this number is not necessarily due to the mental illness itself. This is most often due to co-occurring chronic illnesses like diabetes, heart disease, asthma or COPD, and cancer. And the symptoms of mental illness can interfere with engagement in treatment and management of these conditions, just like it can interfere with engagement with victim services and survivor empowerment. And especially important right now, these are exactly the conditions that put survivors with mental illness at risk for the transmission or severe illness or even mortality due to COVID-19.
Okay, so I want to talk about the dimensions that support recovery. This was taken from the Substance Abuse and Mental Health Services Administration. So when we talk about mental illness, we tend to see it as this somewhat stagnant condition where it may ebb and flow, but we don't talk enough about recovering from mental illness, or even that is possible. And so these are focused on that, but as we know, it can definitely apply to survivorship. So the first one is health, overcoming or managing one's diseases or symptoms and making informed, healthy choices that support physical and emotional well-being. Home, so having a stable and safe place to live. Purpose, conducting meaningful daily activities and having the independence, income, and resources to participate in society, whether that includes employment or volunteering or just general engagement within their own community. Folks who are living with mental illness are not very visible in their communities, and if they are, it's most likely because their mental illness is not visible and they do a very good job of playing the part, so which is unfair, but keeping that in mind, that being having a purpose and being a part of your community is important. So again, as we talk about community, having relationship and social networks that provide support, friendship, love, and hope. So I want to ask you guys, in considering these dimensions that support recovery, what are some ways that these might be affected due to this world pandemic? Either that you've seen yourself or that you can think of. You can use the raise your hand feature so that we can unmute you. Or you can ask the question in the Q&A box or the chat box. This is the weird part where I sit in silence. But I know you guys know this. I'd be really interested to hear what are some unique challenges for some of the people that you serve, that you've seen during this pandemic, that relate to these dimensions of recovery. Let me check and see. Okay, so Sue said having challenges differentiating, excuse me, between real dangers and fake conspiracy theories. Oh, okay, I understand. So like fake news versus real news, and like propaganda over centralization. Wow, I am messing up on my words. I'm sorry, y'all. But yes, thank you. I appreciate you. Yeah, definitely. That can be a huge one, especially for someone that may be living with delusions, and having like natural, any other time having having issues with knowing what is a delusion and what is real. And we as service providers should always keep in mind that somebody who is experiencing a delusion or different ideas, that is very real to them, and we need to support that. Heather?
Yeah, whenever I'm encountering somebody that has whether it's a delusion or they're just they're just very adamant about believing something that might be a conspiracy theory, or we're seeing it so much now on social media. Like my own friends often post things that are they're not backed up by science, or they'll do the copy and paste stuff that says experts say, and it's not attributed to anybody, so that you can check out if they're an expert or not, or where the information comes from. So we're seeing that all over the place. And so how do you deal with that with somebody who's really into it, and might be putting themselves at risk because of that? And I usually say, especially with somebody who is really experiencing that as real to them, it's important not necessarily to challenge a delusion too hard. That can actually just kind of drive them away from you. It can be helpful to just kind of work with them. Okay, how do you feel about, how are you dealing with this? What's your plan to stay safe given this information, and things like that. So you can kind of help them come up with something that's going to be safe for them, be maybe a healthier behavior to deal with it, and not just have them push away and be like, this is so real to me, you don't understand what's going on, by just saying, no, this isn't real. And then you can kind of guide them towards some of the information that might help them accept what's really going on. But I would say in those cases, to like always ask if they have talked with a provider about this, just to make sure that they have the right information. So.
We had another, Abby said, the pandemic has put a lot of clients back into a survival mindset or mode. For example, they are worried about the basic needs such as income, food, shelter, etc., which makes it more difficult for them to access their coping skills. Absolutely. And this isn't particular to folks that are living with mental illness. I'm sure that we're all, doing that as well. And then Terry Shane said, I feel like it is a challenge to help clients find therapists that are a good fit for them. they seem to not like anyone because they feel like everyone is working against them. How can I help them feel more comfortable? Heather, do you want to take that one?
Yeah, that's something that I've struggled with as you know, as a mental health professional too. One of the things that you can do that I've found beneficial is to see if there's an organization, whether it's through the community mental health center or a drop-in center or another peer-run organization in your community or region that offers peer support. Sometimes, you know, sometimes when I was doing this work directly in the field, by making that connection, or even just being their intake person at the clinic, was able to be kind of a bridge to therapy. You know, I think that sometimes, especially survivors, we can go into therapy thinking that, you know, you haven't been where I've been. I'm not going to connect with you because you're basically preaching to me out of a book. And and that was often my own attitude sometimes. And I was lucky that I was able to find a therapist that worked well with me. It takes time, and that's certainly something to reassure folks about, that, you know, they may not go into their first session with a therapist and just be like, oh, I want to see this person all the time. And it's tough right now because services can be somewhat scarce, in order to you know, give people the choice of what therapists they want to see. I know in a lot of practices where there might be multiple therapists, one thing you can encourage them to say is, you know, if they don't feel comfortable with that person, ask if it's possible once the evaluation is done, can they see someone else? I know the clinic that I worked at would do that occasionally. So the other thing is, you know, if they're going in for an evaluation with someone new, help them come up with a list of questions that they want to ask the therapist. It's not all about the therapist just asking them questions. You know, they can ask, you know, what is your particular experience with this? You know, they can, some therapists will answer some kind of personal questions about like what hobbies they enjoy and things like that. So you can kind of make a little connection on other life experiences. But just knowing that most will not like self-disclose any personal information, especially during an evaluation. But yeah, if they have questions that they want to ask the therapist, that's a good way to sit down with them and say, okay, what do you want in a therapist, and what questions can we ask to make sure that you're getting the right one?
Yeah. Okay, so a few other things. Somebody mentioned employment. So loss of income or decreased income, or forced to work in unsafe conditions. And with that could be a loss of purpose. Folks may be experiencing new symptoms that are arising, and possibly new diagnoses. And then isolation. For a lot of folks, it may be difficult to be, quote unquote, stuck in your head by yourself for that long. They may have limited, if any, interaction with other people, their community, or the outside world. Touch is a very important thing for us humans. And while we're self-quarantined, especially if you're just by yourself, you may forget how long it's been since you touched somebody, and you may be struggling with that, or maybe after a while, you finally do give somebody a hug, and it suddenly hits you that, wow, it's been a month since I've touched another human, and that can be very overwhelming for both. And then also, as we know, rates of victimization are increasing because of self-quarantine. So if somebody is home with somebody who causes harm, and looking beyond just intimate partner violence, so not just their partner, spouse, but this may be a roommate or a parent, a sibling, or even a friend that causes harm. Maybe the survivor has done a lot of work to set boundaries and to maintain their own safety, but because of current events, they may be forced back into that space with that person. And then with that, being in the home, so dealing with manipulation, gaslighting, being unable to physically leave, abuse may, or harm may be increased, they may be monitored more. This isn't clicking. All right.
Okay. So this is definitely, of course, we all know that life has changed for so many of us, and we don't have a lot of control, and we don't have a lot of knowledge about what comes next. But I wanted to really quickly go over, some of the things that have changed both for providers and for people living with mental illness. Certainly, the number one concern being reported by patients that providers have told us at NAMI Iowa is increased anxiety, and that's often driven by the social determinants of health. So a lot of the stuff that Nadia just spoke about, housing security, job security, safety during your job, transportation is even bigger now. There's a lot of bus services cutting their routes, or even not operating at all in rural areas. Do they have a natural support system? Do they have that safe home life? And then for people living with mental illness, how this is coming out is my services have stopped coming to my home. I can't connect with friends and family in person, and that in-person connection is so important. I can't afford to get groceries, medicines, or supplies, and certainly we're seeing so much of that. If you can't afford to stock up, you're kind of out of luck when you get to the store, or people can't get to the store. I don't know who I can call for what. I can't afford to stay home. And even if my services are available by telehealth, I can't afford the Wi-Fi or the device to see my providers. And then the next one. One of the things to keep in mind with this too, and why you might hear an uptick in calls to you if you're working with someone, their services may be reserved or focused more on crisis response and management than just the day-to-day services that they would usually get. And it's important to understand in working with their providers, if you're doing co-advocacy or things like that, is that it's usually not up to that particular provider. I know in this situation, if I were still doing direct service, I would still want to be at least occasionally seeing my clients in their homes, because not all of them would have access to me even by phone. It's usually a leadership or a system decision. And it is designed to help keep us safe, but then we have to consider, how much access do people have? Individual providers just don't have control over that usually. And then thinking about at your own organizations, what emergency policies might be in place that can cause barriers to survivors and people with mental illness.
I'd like to make sure I didn't miss a slide. Hold on. I might have missed a slide. Sorry.
No, that's okay. I think I see the next. yeah, the benefits and barriers. So with the everything going to virtual services, especially, but even with in-person services, I mean, some of those things to keep in mind is, you know, are the services, whether they're the victim service programs or mental health programs, or even general health care, are they sober only services? Are they crisis only? You know, the policies meant to protect the service providers can leave clients without services that are life sustaining. You may have clients that receive some home and community-based services that usually come in and help them do grocery shopping or help them clean. And while we don't usually think of those as like the essential life sustaining services, for somebody with severe depression or somebody with schizophrenia or schizoaffective disorder, especially like keeping those routines and keeping things up in their home, keeping their environment the same, are incredibly important, and those are life-sustaining services. So you might find that people are going to call more often. You know, with everything going virtual, it does give us the you know, the benefit of the people that can access it. Allows people with mobility and transportation issues to stay at home. It can make interpretation services more accessible. A lot of providers have access to the virtual interpretation services. I use those a lot at the clinic and hospital where I worked. And some providers are expanding hours because of this. Some places are offering some crisis services and also expanding their hours to evenings for people who are having people who are essential workers. Then the barriers, though, that creates is that there might be a lack of notification of services. I've heard from providers who've said that actually their services their caseloads have gone down because everybody is, of course, being told that you can't go into a clinic and see your doctor. So why would you be able to see your therapist? You know, so just not knowing that, you know, phone and virtual services are available. Then, of course, the lack of access to Wi-Fi or devices. Some people still have limited phone minutes because they have a prepaid or government phone. And then something to keep in mind too, as you are working with folks, is that tone and expressions can come across very differently online or over the phone, particularly over the phone, but even if you're doing video services, you know, I may come off with, you know, a different tone that sounds or something like that at some point, and you might get a, well, who are you to tell me that, or they might just shut down a little bit. So keep that in mind if somebody does that, if they you know, don't respond or don't shut down, and just kind of, you know, just watch how you're wording things and how we say things. Some providers are also limiting hours, and there's more doors that you have to walk through now to get to the services. We talk a lot about trying to create a no wrong door to get to the service that I want, but you know, people are having to jump through a whole lot more hoops, and there's a whole lot more people seeking these services.
I swear I'm clicking it. So let's talk about some solutions. For you guys, be intentional about outreach, whether that's notification of your office being closed or support groups being postponed or canceled or switched over virtually. Typically, we tend to utilize social media and our listservs, or like newsletter lists that may be more community-based, and then our like agency websites. but consider that there are a lot of folk and survivors and even clients themselves that don't have access to these. They're not on these listservs. They're not checking the website, frequently, and they may not have you on their social media, especially for, typically for our social media sites, it's usually our like community partners and collaborators. We do have a few survivors that will follow social sites, but for somebody who is a survivor, they may not want, on their Facebook page for their friends and family to see that they have liked and followed this rape crisis center. And so think more about how are you getting that information out to the people that you serve and your community, and in what avenues are you utilizing, and what are some gaps, and really think about it and even ask around so that you make sure the information is getting sent out. You're covering enough area. Utilize plain language. In this work, we really love using our big fancy terms or buzzwords. So like trauma-informed care or vicarious trauma. And for folk that's just not language that is common unless you're in the work. And so try to utilize plain language in any materials that you're using, or even like status posts or updates in regards to your services for your agency. You can definitely do some Googling, and you can find like generators that you can, like if you type something out, you can copy and paste it in there, and it can identify what level of like plain language or reading level that it's at, so that you can make adjustments and changes just so that it's more accessible to everybody. Be aware that, as Heather said, tones and expressions may be perceived differently. During conversations with the people that you serve, making sure that you are being affirming and that you are checking in periodically, and also mirroring, which is, I mean, a lot of you guys know, or at least do this without knowing the term, but typically if somebody goes on for 15 minutes just like word vomiting all this stuff, and then they waiting for your response, and you respond with so from what I'm hearing is that you are struggling with X, Y, and Z. Is that correct? And checking in to make sure that you guys are both on the same page and both understanding what's being done, because they may say, no, I wasn't even talking about that. I was talking about this. So we typically do that already as advocates, but try to be more aware and present when you're doing that, and utilizing it more. And then funding flexibility. Because of this world pandemic, there are a lot of funders that are saying that their funds, they're being very flexible with how their funds can be used. So you can, of course, please check with your grant manager first. Please don't say, well, IowaCASA said that we can use this money for other things. But check with your grants manager and see what flexibility or considerations are available to your organization now with the world pandemic, because previously restricted funding may be approved to be switched over to client assistance funds. I know that a lot of our programs have depleted most of their client assistance funds, and clients are in need of more financial support more than ever. So being aware of that and looking into it and seeing which ways that you can do that. And with this clicking. So when we talked about lack of access to Wi-Fi or technology, things like that, oftentimes programs will have Wi-Fi at their building, and they tend to have like a private one for staff and then a public one for clients. And since we're all working from home, maybe you might have staggering schedules for in office, but think about if you have clients that don't have access to Wi-Fi and they can't really go to the library or go to a local restaurant or a coffee shop to use their Wi-Fi. Maybe you can have them come in and offer that up to survivors that, you know, from this time to this time on these days of the week, you're more welcome to come and utilize our Wi-Fi in our lobby, or set up tables and chairs outside. Get creative with how you are providing services. Compassion, patience, and understanding for frequent calls, because that will happen. And also being open to receiving more calls, because, especially because survivors' health providers are not available, but advocacy still is. We are still operating on a 24/7, 365 basis. And then looking at what services you provide and how they may look different now. So maybe some of your clients may not be focusing so much on their victimization and focusing on other concerns or barriers that they're facing, but that's still a part of your work and services. And then for supervisors, making space, for your team to ask for help. Recognize that you are all going through the same stressors, primary traumas at the same time as your clients. This is a very unique situation, and it's okay to ask for help. And I say this because I know we're focusing on survivors who are living with mental illness and how they're dealing with this world pandemic, but we're also living through it too. And so I want to recognize that I know that this is affecting you all individually. And so addressing that collectively and making space for your team, not even as a supervisor, even if it's just peers, to try to develop ways to manage this and to get through it, and making sure that you guys are taking care of yourselves. I know we tend to use the term, you can't pour from an empty cup, but it's true. And so I please know that in this presentation, we're not trying to dismiss that a lot of this stuff you guys are struggling with too, and you guys are affected with it, because that's very real. And so please, take care of yourself during this so you can continue to serve the survivors. Okay, so we're gonna have Dr. Megan Srinivas join us. Megan, if you want to introduce yourself, your name, pronouns, and then talk about what you do and your work in general.
Hi, everyone. Thank you, Heather and Nadia, for hosting such an important informational session. So my name is Megan Srinivas. I go by she, her, and hers. And so I am an infectious disease physician and public health researcher. I'm originally from Fort Dodge, Iowa, which is where I grew up. I left for school, as you can see here in the slide, and moved back to Fort Dodge a few years ago, where I do practice at our community health center, but I'm also still on the faculty at the University of North Carolina and do education there and some inpatient time there, and work on a lot of global health issues. So I'm able to use Iowa as my base, but still be able to travel around for the work I need to do in my research side of life. Right now with COVID-19, all of that has, of course, been impinged and put on hold. So based now in Iowa, I get to start a garden and live home life a little bit more and less travel, which has been nice from that standpoint. But definitely this is a stressful time for everybody and a very hectic time for everybody. So this is a very important topic that we're discussing here with mental health and the implications of COVID-19.
Thank you. Thank you so much for being here. So for you all that's attending, we really would like to provide the opportunity for you to pick Dr. Srinivas' brain. So if you have any questions, please use the raise your hand feature, send it to the chat box, or preferably the Q&A box. But to start off, wanted to ask you, if most people just get mildly ill from COVID-19, why do we have to practice social distancing? And what effect does this have specifically on people who are living with mental illness?
So great questions. So like you said, 80% of people will either have no symptoms or just mild symptoms from COVID-19. But the other 20% end up often requiring hospitalization and can even pass away from this disease. So that's 1 out of every 5 people. The problem with a disease like COVID-19 is it's far more contagious and easy to spread than any other disease that we've really faced in recent times. When we look at COVID-19, because it's a respiratory illness that produces and passes along through droplets, and it can survive on surfaces for days, you can pass it to people without even knowing that somebody infected was in your area, and you can pick it up from being in that area. When we look at the penetrance of COVID-19 into the population, we expect it to infect anywhere from 50 to 70% of the population worldwide. So if we look at that, say 50% of the US population of 300 million is infected, that's 150 million people. And 1 out of every 5 having a severe hospitalization would make it 30 million people. So that's still a large number of people. Even if the majority only have mild symptomology, that's still a large number of people that could get severely ill, have permanent effects such as lung damage, kidney damage, heart damage from this disease, and even die from this disease, which is why it's so important we do the mitigation factors. This graph here actually just shows the comparison of fatality rates between flu and COVID-19. A lot of people have thought that COVID-19 is like the flu. It's nothing like the flu. The flu has a certain amount of herd immunity that already exists in our population because every single year it's just slightly different than the virus we'd had prior years, plus the fact that we have a vaccine available for it. So some people are already protected due to prior protection or prior exposure, but then the vaccine helps to kick in to increase our herd immunity. Unfortunately, with COVID-19, we have nothing like this in the past, meaning not a single person in our world has ever had exposure to it prior to this pandemic, meaning everybody's susceptible. And on top of it, we don't have a vaccine, and we don't even know if antibodies are actually protective against reinfection, meaning that if you've gotten the infection once, you might be able to get it again, which is why it's so dangerous, so scary, especially because it's so quickly passed and passed to so many people. Looking at the fatality rates between flu and COVID-19, you can see a drastic difference. This graph here just looks at the overall ranges between different ages. And for every single age group, there's a significantly higher fatality for COVID-19 than there is for the flu. And on top of that, the overall fatality of COVID-19 we estimate to be between 0.5 and 3%, somewhere in there. The problem is we don't have enough data to know what the exact fatality rate is right now for the overall population. But even with that, that's at least, at the lower end, at least 5 times more fatal than the flu. And it's infecting more people. So overall, that's why it's such a deadly disease. And unfortunately, because it acts so quickly and transmits so quickly, when we have large groups of people gathering together, that results in large groups of people falling ill at once. And we don't have the healthcare resources in our country to be able to take care of all of those people at once. And that's not just hospital beds, not just ventilators. It also includes personal protective gear for all of our essential workers. It includes having enough healthcare workers like nurses, respiratory therapists, specialists in critical care, specialists in intubating patients, and anesthesiologists and ENT docs, specialists in infectious disease to be there to even take care of these patients. We have a severe shortage of that throughout the nation, but particularly in rural America. And a large part of Iowa is rural, so we do see a lot of those shortages. And that's why, unfortunately, we sometimes see the fatality rate even increase above what we would expect for the virus because we don't have enough support services for everybody to get the care they need. So given all these issues, very different than the flu, very important that people do everything they can to stay home and prevent transmission. That's the bottom line when we're discussing this in comparison to the flu.
So we had a question come up. The question is, how do we move on? We can't social distance forever. We need to get back to a new normal at some point.
No, and that's exactly right. if we took the right public health interventions at the right time, we would have been actually back to normal by now. All the modeling shows that if we had done strict social distancing and a stay-at-home order, because of Iowa's low population density, it would have worked to our advantage, and we would have been able to control the infection within 2 to 3 weeks and been back to normal by now. Unfortunately, because as a nation and as a state, we acted very slowly and even then very lackadaisically, meaning we didn't really put into effect the strict regulations we needed to. We are seeing still an upward trajectory in our infections. And unfortunately, Iowa is actually one of the fastest growing hotspots as a state in per capita infection rate, which means reopening right now is actually extremely dangerous because this is the time when the infection is at its highest infection rate, highest prevalence or presence in our population, meaning that you could be interacting with people and passing this infection left and right and just continuing the transmission cycle and increasingly infecting more and more people, increasingly resulting in more and more hospitalizations and deaths. So that's really the risk right now. How we mitigate this is so important. And that's why ramping up testing is a key factor in trying to mitigate this. Over the last 7 weeks, while we were doing more social distancing at a statewide level and even a nationwide level, that's really the time when we needed to ramp up our test production. We needed to ramp up our PPE production, our protective gear production, and get it to the people who need it, the essential workers who really need to have those tools so that way they're available to gauge what the penetrance of the infection is in our communities and to be able to do targeted interventions so we could reopen segments of our community. That hasn't happened, but it's something we still need to push for. We need to push for more testing. In a state like Iowa, we need, well, actually anywhere in the country, the modeling from Harvard Global Health Institute shows that we need 152 tests done per 100,000 people on a daily basis in order to actually get the data we need to understand the safe routes for reopening. In a state like Iowa, where we have 3.155 million people, that equates to at least 4,700 tests per day. And that's unique tests, not meaning a second test, a third test, but 4,700 unique tests per day. And so we're not even close to that. There have only been a handful of days that we've passed 2,000 tests in Iowa. So ramping up our testing capacity and doing it soon is going to be extremely important to being able to reopen safely. Another issue is actually instructing people to utilize protective gear like masks and face shields, because not only does that help to protect yourself if you're wearing a face shield, but by wearing even just a mask, it helps to protect you from transmitting it to others around you. Because with every time you speak, every time you breathe, there are droplets coming out of your nose, out of your mouth, that can infect anybody around you. And unfortunately, the majority of people who are passing this disease have no idea they're even infected. Only 40% of people who are infected with the COVID-19 are getting the infection from somebody who had symptoms at the time of their interaction. The other 60% are getting it from non-symptomatic sources, meaning either people who will never develop symptoms, people who are in that 2-week period before they develop symptoms but are already carrying the virus, or through an environmental contact where somebody had touched a doorknob that you then touch after them and they had been infected and you pick up the virus. And that's why it's so important that everybody wear face masks and everybody try to protect each other from transmitting that virus, because you don't know if you're a carrier even if you don't have symptoms. And you don't want to be the cause for your neighbor to end up in the hospital unintentionally, or somebody in your own household if you pick it up from somebody else. So while we do need to figure out ways that we can reopen, these are simple mitigation strategies that really require our leaders to amp up production and focus on the right public health interventions. The other issue that we also need to address is contact tracing. It's something that should have been done from day one with our cases. And unfortunately in Iowa, the majority of counties still aren't contact tracing. And without doing contact tracing, we can't ensure that the virus isn't being spread, and we can't warn those who might have been exposed to get tested. And that is something that needs to be instituted and as quickly as possible.
Thank you.
Mm-hmm.
Megan, you kind of touched on some of this already, but we were actually talking earlier, somebody had a question about how to support people who are believing in some of the conspiracy theories about COVID-19, but then also going along with that, the people who have outsized anxiety about the virus, including, thinking like last November, I had this really bad flu, but I think I had it, I need to get tested, or not knowing whether they have it now, whether they may have been exposed, and anxieties surrounding that. So how would an advocate or a provider be able to reassure clients, or how can they help them know when to get tested if they need a test, and how can they help them get to one?
Yeah, so those are great questions. One of the best ways to help reduce stress and anxiety levels during a pandemic is really by getting information. The more information people are armed with, the more in control of a situation people feel. That's the same in many situations, but especially in a pandemic, the more transparency we have from our government leaders, the more information we can be armed with, the more we can be reassured as to whether we're at risk or not. So being the people who are often dealing and being the providers where you guys are seeing these patients who are having stress and anxiety from these situations, are having to figure out ways to cope, and are also people that are going to be dealing with PTSD, because as a population, this is a very traumatic situation for everyone. And the PTSD we're going to be seeing is going to go on for not just in the immediate future, but in the long-term future following this pandemic. So those are all things that we have to mitigate. And the way that we can mitigate that from a mental health standpoint is really arming our patients with accurate information and sources of information that they can go to reliably. There's a lot of misinformation out there, which only heightens fears, and a lot of confusion as to who should be listened to, because even within our leadership, we've heard a lot of conflicting messages. So getting clear, concise information to your patients, and also having one source that you can say, this is somewhere you can go and you can always trust that information, is extremely helpful to help patients navigate through such an anxiety-driven time. And did you have a second part to that question too, Heather? I feel like you did and I'm forgetting it.
Just if somebody does need a test, what's the current process, and how could I help them get a test?
Yeah, so unfortunately, that's a really difficult process right now. There are different clinics that you can call. I know that several of the federally qualified health centers throughout Iowa, there's 78 of them. Not all of them are, but several of them are offering tests that don't go just to the state hygienic lab, that actually they're using private testing facilities when they think somebody is clinically ill enough to need a test but doesn't meet our state criteria. The Test Iowa criteria is still very narrow because we don't have the capacity through that program yet to ramp up testing to the levels we need to. And so even if you don't qualify in Test Iowa, but you are concerned, I would suggest reaching out to your main provider. And if you don't have one, any of the federally qualified health centers, so like here in Fort Dodge, the Fort Dodge Community Health Center, we're accepting all patients who are concerned, and examining patients and offering tests as appropriate based on their exam.
So I know that you have to leave us soon, but I want to get one more question in that I know can be really beneficial to advocates. So what can advocates do to remain safe when they have to provide in-person services, especially responses to hospitals?
Yeah, that's such an important question. As advocates, you guys are so critical during this time, because it's not just physical health, it's mental health. It's a really high, that's a really high burden situation. And so your work is so critical. And it's important that you stay healthy at the same time. One of the biggest ways you can stay healthy is by wearing the right protective gear. And unfortunately, PPE is in a major shortage here in Iowa. So trying to, if you can, have access to an N95 mask when you're interacting with patients. Trying to ensure, if you can, that you have a face shield. If you have both, great. If you have a surgical mask and a face shield, great. If you have to choose one or the other, at least a face shield. A lot of companies have been using some of the resources to make free face shields for people in the healthcare industry. So you might have one in your backyard. I know Mason City has a few manufacturing sources, but reach out to your county public health department because they often have a connection and might be able to at least get you a face shield for free. And that alone will be a huge step up in helping to protect yourself from droplet and infection contraction. On top of that, I would say washing your hands frequently. Anytime you are going to touch your face, wash your hands. Anytime you're going to eat, wash your hands immediately beforehand. Anytime you've had a patient encounter, wash your hands multiple times, probably during that encounter. Avoid having food anywhere around other people, around your patients. Avoid it in any places where you have worked. So if you have patients coming into your office, don't eat there. Find a safe space that's very clean that you can eat that nobody else has contact to. And anybody that you're serving, make sure that they are also wearing a face mask, even if it's just one that was made from at home, like a cloth mask, anything they have, as long as they are covering their nose, it's going to help reduce the transmission of any infection to you, which is going to be critical during this time.
All right, thank you so much for all of your wisdom and insight. Unfortunately, I know you do have to go. If some of you still have questions, feel free to send them in the Q&A box. We will definitely forward that along and get those answered for you and pass that on.
Yeah, thank you guys so much for hosting this. This is so important, and thank you to all of you advocates who are on the front line trying to help your patients through this difficult time.
All right,
Thank you,
we'll see you
Megan.
soon. Okay, so I did miss a slide earlier, so we're gonna go back to that. Give us a second.
It's number
This
11.
one, right?
Yeah, there we go. This is actually kind of a good wrap up before we talk about other NAMI services. So kind of going back to, and also kind of going back to some of what Megan talked about in, helping, but also, keeping yourself safe. In going into people's homes, I also do want to really quickly give you a heads up. If you have questions about that, we will absolutely try to get them answered by Megan. But if you have questions about going into people's homes or after you've been at an emergency department or something like that, I'm happy to give some tips for what I used in certainly some high exposure situations. So, but as far as when some symptoms can create barriers, or you're working with somebody that's high anxiety, or believing some of these things about COVID-19 that are not true, or you're working with somebody who has higher needs because of that. One of the things that I have done with folks, especially in my work with folks with borderline personality disorder, or those folks who just need a lot of reassurance, is because we all have other clients, and your clients will understand that. In order to help manage some of that anxiety and some of the need, what I would do is set up a regular check-in schedule with someone. In a lot of my work, lower needs folks, would get a call maybe once a month, and that would kind of jog their memory, and then they would be more likely to call me when they needed something, when they found out they needed something, rather than waiting for crisis to happen. So that's a really good way. Like, I'm going to call you, or you're going to call me at this certain time, once a week, twice a week, something like that, just to check in. If you don't have anything to talk about, that's fine, but I'm going to set aside this time. Help them update their safety plan. This is something that we often call cope ahead. Have a step-by-step for what they might do if they find themselves in a mental health crisis, before having to maybe call the emergency department or go to the emergency department. But certainly that's one of the steps. I'm going to call this person first, or I'm going to try these self-soothing exercises, and having those things written down, and in a prominent place where they can see that, or something that they carry around with them in their pocket. So we call that cope ahead. Just knowing in advance what you'll do. That can go a long way towards reassuring folks. So, and then a big thing that we talked about earlier is just be willing to repeat directions. We're all experiencing so much more stress right now, and regardless of what if you have a mental health condition or not, we're all experiencing, different abilities to follow directions or follow instructions of what we need to do. But of course, as we noted earlier, that's particularly true for folks that might be experiencing psychosis or just extreme stress. One of the things that I use a lot, there are two parts to this. In healthcare, we call them mirroring and teach back. And you may have learned these before, but mirroring is just to help mitigate tone and perception of what we're saying, and making sure that we understand each other, that I repeat back to you what I think you just said. And I say, this is what I understand you to, or this is what I think you just said. Do I understand this correctly? And then also using that when you have instructions for somebody, or they need some help to get through an application process or something like that. Use that, and it's called teach back. For instance, as a healthcare provider, I can provide medication. So how you take your medication, and setting that up. So I would ask someone to show me what they're going to do. Or once I've given directions, I say, okay, can you tell me how you are going to do this? So can you tell me where you go to file a Medicaid application? Or can you tell me who you need to call to update your food stamps or things like that? Another thing to do if somebody is experiencing a lot of anxiety, or is, might be starting to kind of spin with a conspiracy theory, just kind of do a check the facts and radical acceptance. As particularly with personality disorders, check the facts is a good thing to do. That, oh, somebody so-and-so didn't call me, and now I think they hate me, or they're no good to me. And checking the facts might be like, okay, so why do you think that, just from they're not calling you? Okay, so the fact there is, yeah, they didn't call. What's the other fact there? Did you call them? So things like that, just that, okay, this is the fact, they didn't call, but did you call them, or did you let them know that you wanted to talk? And then radical acceptance is, it's a little harder to practice, and we'll send out a little bit of a helpful guide on this, but it's, just like, okay, goes along with check the facts. The fact is, we can't go outside. Okay. Instead of, I can't go outside, I'm spinning out of control, I'm so lonely, I can't see my friends. Just trying to learn to just be like, okay, this is the fact, I can't go outside. But the fact is, I can also, call a friend and talk to them. I can, I can play with my cats. I can, do other things. I can play a game online. Just kind of accepting things as they are, and trying not to get into all that could be. Another thing that I'll send out some resources on is getting to know the services offered by your local providers. I talked about peer support earlier, especially. That is a core service that is Medicaid funded, but also there are some services available through the mental health and disability services regions around Iowa. There are 14 of them, and I will be sending a map and a link to a map and the contact information for those offices. They'll be able to tell you where peer support exists or what other programs exist, if there's a mobile crisis unit in your area, if there are crisis stabilization, if somebody needs it, and where that's at and how to get to it. They're great resources for that. You know, are there virtual support groups that you can refer folks to? NAMI is running some virtual support groups now for both family members and people with mental illness. So they are focused on the mental health aspect side of those things, but that's a great way to kind of co-advocate and to connect people with others and with an organization that can help answer questions and help them out when you can't. Help them plan to check in with friends on certain days. I've seen a lot of people, you know, kind of making a schedule of, I'm gonna call and talk to this person on this day and another person on another day, just so I'm making contact with people. And then advocates and providers themselves. We're experiencing the same type of stressors at the same time as our clients, and that is extremely unusual. And in talking with some therapists, again, a lot of this is kind of actually turning therapy services almost into peer support services in a lot of cases, where instead of necessarily working on the usual skills development, you're working on modeling healthy behaviors and saying, you know, this is how I'm getting through this. You know, does that apply to you? Is this something that's interesting to you? You know, and a lot of times we get that back from our clients too. I can't tell you how much I learned from my clients just by doing that and by sharing, you know, that, hey, you know, we're going through some similar things at this time, or I've gone through this before and this might work for you. And sometimes they come back with like, oh no, I have this idea. And I learn a lot from them as well.
We say it twice for a reason. So I did have a question come up. It says, you talked a little bit about this, but I wanted to verify about social media. Since clients are not able to get as much support as we are wanting, we are looking at setting up a private Facebook page for our clients only to be used like a support group for each other. They will be vetted through our advocates and will have to answer questions about the rules before they are approved to join. It will also be monitored by a staff member. Do you have any suggestions or things we should be looking for? Yes, that is a lot of stuff to cover. First of all, that's a really unique and creative way to connect survivors when they may be isolated. So props for that. As far as the first thing that pops into my mind is providing adequate notification to members that that you can't what's the word, promise confidentiality. It's a public, I mean, yes, it's a private social site, like a private Facebook page, but it's still on a public social platform, and we don't know who has passwords to other people's accounts. And so if I'm a survivor and I'm a part of this private group, I might have a sibling that has my login, or, you know, maybe the person that's causing me harm has access to all of my passwords and logins. And so know that making sure to let everybody know that you really can't promise confidentiality in that space. And then as far as having a staff member like monitor the page, that staff member's profile will be connected to that page. I know I've heard of a lot of advocates having a personal profile and a professional Facebook profile. And so definitely if that's the case, have the advocate utilize their professional profile to connect to that, or create one. If not, going through your profile and first of all, checking your privacy settings. So I know on my profile, unless you are a friend, you can't see anything but my name and like my image. No, like nothing is available. And so looking at looking through all that and making sure that the privacy settings are in place, and making sure there's no identifying information. I'm getting some of it. That is in the rules. I've created a work page and a stuff. Okay. And then really going through and what helps me is creating like a work plan. So like who, what, where, when, why. So what's the purpose of this group? Is it to act, and you mentioned like as a support group, is there also going to be resource sharing? Is it notification of like updates and like hours and services? Make that very clear and include it in the community guidelines. And then looking through how clients are being vetted into the space. Is it just when they try to join the space, they have those questions, or is it they're working with their advocate to figure that out? And then also seeing what's necessary for vetting, because I don't want any survivor to be refused access to this space. And so being careful about what qualifications you have in getting approved into this space, and making sure that it's not creating new barriers for survivors to get access. And then looking at who staffs it. Is it just one advocate? Is it all the advocates and it just cycles through? What happens if they leave? Do you have a process in place so that if somebody moves on and goes to another job, that you get them taken off as admin from their personal profile so they don't have access to it any longer? There was another question that I had, but it's a lot, and I would love to talk to you more. So please feel free to give me a call or email me, or any of IowaCASA can help, especially I think Nadia might be a good person for this, but I would love to talk more about this and help get this set up in a very intentional way that doesn't create new barriers. Okay. Go back to where we were. All these things. Oh, okay.
I can actually answer Julie's question. Julie had another question about has anyone else tried it? I do know that there are a couple of NAMI affiliates that are doing this. One in particular off the top of my head is NAMI Central Iowa out of Ames. They've created some very kind of thematic closed Facebook groups for folks to continue to connect. They've been very intentional about, this is not meant as replacement for treatment. This is a way to connect with others, but also, you should be aware of what you're sharing. They have specific rules laid out about, not to share this beyond the group, but also laying out that you can't necessarily control who else has access to someone's account. Additionally, on any social media, you never can control or even know sometimes if somebody's screenshotting something, and sharing things that way. So those are definitely things to make sure that all participants know about before signing on, and taking part in this, and having that prominently listed you can pin a post that has like the group rules and things like that. So it's been done in our NAMI space, And I could always certainly connect you with the group up in Ames that, or the executive director out there that started that. So
it's also a really good something that just popped into my head is setting one of the rules as something like respect each other's boundaries, and in the description, no one is expected to accept friend requests from this group, just so that you lay it out, because maybe somebody wants to be a part of it, but they don't want to add a bunch of people as friends to have more access to their profile or their personal life. And so even like, having that stated out can help mitigate any, hurt feelings. Thank you so much for asking that question. That's a really, we all we're all switching to virtual. We're all trying to navigate this technology and find creative ways to continue and like maintain services. So, yeah.
So I just wanted to give a few community resources, and of course I've talked about a few more that we'll send out more information on after we wrap up. But there is a 24/7 crisis line for statewide access now in Iowa. That is run by Your Life Iowa, and you can call or text it. It is 24/7. It's free for people to use, and they provide crisis counseling, and will also kind of help people work through a safety plan for at that time. They may also, depending on the area, they may also have some contact with the person's provider, and be able to just send a notification through that this person called the crisis line. I know when I was doing services up in Fort Dodge that the regional crisis line had that ability to let us know. And then NAMI National also offers free crisis counseling that's available by text 24/7. And that's just the 741-741 number, and you just text NAMI to it, and they'll connect you with someone. Some people are just more comfortable with text. And then this is not a crisis line, but NAMI Iowa operates the Iowa Office of Consumer Affairs. And it is a helpline for anybody statewide to access resources and referrals to mental health services, community resources. So if, for instance, you have a client who might be moving and you're not sure where the resources exist in their area, or where to get them set up with providers and things like that, they can call us. And there's a little more information on another slide too that about that. Our office hours are 8:30 to 4:30 Monday through Friday. Right now, because most of us are working remotely, we do have one person who is in the office answering phones, but it might require a call back from us, or can access us by email. Of course, at any time, just the answers come during office hours. But, if somebody has a question at midnight, I don't want them forgetting about it. So email us. But certainly we can answer questions that way. And we work with anybody. Survivors or people with mental illness can remain anonymous if they want to. This is a contract that we hold with Department of Human Services to provide this service, but I always preface that we are not mandatory reporters. We're not certainly learning any of information in order to report anything. It just gives us access to DHS and to Medicaid if a client or if a caller wants us to, that we can help find out what services they might qualify for. But obviously, people can withhold their names or contact information, whatever they want. But even when we document calls, we strip personal information out of anything that might be documented. We just share aggregate call data with DHS so that they know what types of calls we're getting and what the service gaps might be in any particular area, so that they can hopefully work on policy to address it. But again, can remain anonymous or not. It's certainly that person's choice. You can follow NAMI Iowa on Facebook as well. And we do a lot of updates about different services that are, new services that are coming up in different areas, as well as, sharing articles about, new program development, as well as you can keep up with what's going on as far as our programs, any trainings that we're offering for the NAMI signature programs, and how to reach your affiliates as well. So again, more information. This is for everyone. We at the OCA and NAMI Iowa, we get calls from family members. We get calls from survivors and people with mental illness. We get calls from providers as well to ask about, if somebody needs discharge planning, somebody needs access to a therapist, they're not sure where to find one, or they want somebody who specializes in something, not sure how to access residential services, how somebody gets on Medicaid, or how somebody gets on habilitation, home and community-based services, things like that. So, this is statewide. Feel free to send us questions. This is staffed by my coworker primarily. Her name is Emily Berry, and she's a trained peer support specialist. And then I also will assist with answering calls, especially if it's with regards to services for survivors, or oftentimes like criminal justice issues and things like that. So you'll get forwarded to the correct person, and we'll call you back or email you back. You can certainly, my information is later on, so you can certainly email or call me directly too. So we can help with Medicaid and coverage questions as well, service information. We can do a little bit of peer support for folks that are calling in for themselves and just want to talk through an action plan. We offer virtual support groups for peers and family members. We now have a provider support group that's actually starting tonight. We do provider resources and offer technical assistance. We are working on a best practice toolkit for healthcare providers in serving people with mental illness, and we hope to distribute that widely, especially during this time, working with people during a pandemic. And then we do a lot of legislative and systems advocacy at the state and federal levels. And we have a day on the Hill that, it's somewhat similar to IowaCASA as well, but we invite our membership and the families and peers to come and take part in a training. We usually have, around 125 to 140 people, and usually half of them are first-time advocates. So that's something folks can take part in that helps them learn to advocate for the services they need.
All right. So with that, do you guys have any additional questions? You can use the raise your hand if you want to unmute yourself and ask a question. While we're waiting for that, I want to thank you all for registering and joining us today. I hope you all are doing well, and I really wish I can see your faces, especially since I know a lot of you guys. I miss you guys so much. But thank you again. As a reminder, we are offering 2 continued education hours for certification for advocates for attending this. You will be receiving an email from our lead training specialist, Kelsey. She will reach out to you individually to provide that to you with confirmation that you received that, and also send you a link for our evaluation form. Please fill that out and be honest so that we can hear your thoughts and learn ways to be better. All of the resources that we have mentioned, we will send out to you guys as well, so that when you get the email from Kelsey with the evaluation link, she'll also have the slides and resources that we've mentioned. Oh, Cindy, I miss you too. Don't get me started. I'm gonna start getting emotional if y'all start laughing at me. Our information is here. Please reach out to us if you need anything. I know for Heather and I, our phone numbers are our office lines, but for Heather, they have somebody answering the phones at NAMI, and so can pass along the message. For me, if you just leave a voicemail, I'll get an email with that voicemail, and I'll get back to you. Otherwise, feel free to email me. But besides that, I haven't seen any other questions come up. So with that, thank you one last time. And I hope you guys have a good rest of your day and a good weekend. Take care of you guys. Take care of yourselves and your loved ones, and be safe. Right, bye.
Thank you, everybody.
Oh, I need to figure out how to stop. Oh.